Okay, so now that everyone's had a nice little break, we're moving on to the next agenda item, discussion and consideration of pharmacy law related to collaborative practice agreements. There are several provisions in pharmacy law that establishes authorities for pharmacists and advanced practice pharmacists to perform functions under collaborative practice agreements. Specifically, in our law book under 4052.1, which in general provides the authority for pharmacists to order and perform routine drug therapy, patient-related patient assessment procedures, order drugs based on related lab results, administer drugs, biologicals by injection, initiate or adjust drug regimen pursuant to policies, procedures, or protocols as specified by a licensed healthcare facility. And one of the things I think is most important is to understand that it says initiating or adjusting drug regimen of a patient pursuant to order or authorization made by the patient's prescriber. So it's fairly narrow. 4052.2 in general terms provides similar authority to pharmacists, including what I just read, the prior section, but allows for procedures to be performed in other healthcare settings, including licensed clinics and other licensed facilities owned and operated by a health service plan. Once again, 4052 has a reference in it also that says initiating or adjusting the drug regimen of a patient, so singular patient, pursuant to a specific written order or authorization made by the individual patient's treating prescriber. So once again, fairly narrow. 4052.6 in general provides the authority for advanced practice pharmacists to participate in and evaluate disease and health conditions in collaboration with other healthcare providers. 4052A9, 4052A11, 4052A12 provide general authorities for pharmacists in any setting to participate in interdisciplinary review of patient progress, administer vaccinations, and order and interpret tests. So the committee looked at or noted that in a lot of the healthcare models today, as they've evolved, and as Mr. Weiser stated when we were talking in the past agenda item, the patient access points, that it's appropriate to evaluate our current collaborative practice agreements to determine if our pharmacy law has remained current with the national trends and really patient care needs. And probably the key thing here is kind of the new term called, population-based health. So pharmacy law declares that the practice of pharmacy as a profession needs to be dynamic and patient-oriented. And we have a scientific body of knowledge to improve and promote patient health by means of appropriate drug use, drug-related therapy, and communication for clinical consultative purposes. So the committee reviewed the National Alliance of State Pharmacy Associations, NASPA, NASPA, report about pharmacists' collaborative practice agreements and looked at key elements for legislative and regulatory authority. We thought that was a good place to start if we're going to evaluate our current collaborative practice agreement and determine if we needed to update it. So in looking at that, NASPA specifically talked about things that if you make a collaborative practice too restrictive, as we determine that ours is currently, it really impedes the innovation within the patient care model and the ability for the pharmacist to take care of the patient. So the committee considered draft statutory language that the staff provided to recognize the continued evolution of a team-based approach. Under the proposal, pharmacists would have the authority to initiate, adjust, or discontinue drug therapy for a patient under the following conditions. Pharmacists are performing the functions under collaborative practice agreement, either a prescriber or medical group, and the pharmacist is aware of underlying medical condition. So the pharmacist might be aware of the underlying medical condition just by their expertise and their the medication that the patient's taking. The committee discussed, we did go through a discussion about whether we should include language that said whose diagnosis is known to the pharmacist, and actually came to the determination that that was too limiting. That too often patients, we're trying to fix a problem where patients are coming in and they might not be able to get to a primary care prescriber. So we might not have a piece of paper or a diagnosis available, and yet we can tell if someone has a cold, like me, or other, obvious disease that the collaborative practice would cover. So the committee decided to move forward with language in 4052 to add in subdivision A13. So this once again would be a new subdivision in 4052. Same area that we were just talking about as far as naltrexone. And what we would add is initiate, adjust, or discontinue drug therapy for a patient under a collaborative practice agreement with a prescriber or medical group. Now that was our motion, and we had a little bit of discussion with the public about were those last couple words correct, a prescriber or a medical group. So we did ask legal counsel to further refine, how best to handle a prescriber or medical group. And in your attachment, just my little mouse here. In our attachment, let me just go to it real quick here, is, give me one sec. Is what staff came back. It's not quite, I don't think, exactly what we were looking for. It's very close. Initiate, adjust, or discontinue drug therapy for a patient under a collaborative practice agreement with any healthcare provider with prescriptive authority. So we would probably, and the collaborative practice agreement may be between a single or multiple pharmacists and a single or multiple healthcare providers. Probably put a period there. Because what we were trying to get away, we were trying to make it kind of be a pharmacist or a group of pharmacies with a medical group. That's where the collaborative practice agreement would sit. So we would need to, since there was a change from our recommendation, I believe we have to get a new motion, right?
I think so, right? Yeah, I think so.
Okay. So I don't know if we want to have any discussion. Is Alan? Is he over there?
Alan's
Okay.
Right there.
So a couple of people from the committee are here. Albert, Cheryl, myself. I can't remember if you're at the discussion.
I wasn't at the meeting.
Okay. But perhaps I don't know if you have any additional comments you want to add, or if we want to take comments from the public on the proposed language, but I think we may want to massage it a little bit.
Right. With the, I was busy talking to somebody else, not more important than you, certainly. So, did you mention the?
Yeah, the prescriptive authority. I know we didn't want to have that as part of it.
Right, it's too restricting.
Yeah.
So, if I may, since I'm the one that
Yeah, Kelsey.
posed this thing. Well, I just wanted to part of their motion was to direct staff to work with legal on massaging the language. So I do want to clarify. When I did research on collaborative practice agreements, the basic definition is that it is a delegation of functions between a prescriber and a pharmacist. And so without that prescriptive authority, there cannot be a delegation. And I looked at other states. Actually, CDC has a great chart of all the different states, and none of them had medical group, none of them had medical entity or healthcare entity as being a part of their collaborative practice agreement statutes or regulations. So, and even most of them were even limited to just like a primary care physician. Some of them allowed NPs, but so I thought that this was one of the more liberal in terms of language.
Okay, so thank you for that clarification. Okay.
Can I
yes,
add to that a little bit, or you want to do it?
Well, just the other issue being that healthcare entities, a healthcare group, does not have the ability to practice medicine. It's the corporate practice of medicine, and so that wouldn't be permitted under state law.
Okay.
Can you just clarify though, because I think collaborative practice agreements are in different settings. So there are groups that are in ambulatory environments or in acute care environments where there are multiple physicians, and each physician does not have an agreement.
No.
But there's a corporate agreement or a
Right.
medical staff structure type of agreement.
Right,
and all included.
And so that's what I was trying
Definitely
to get out with the
supposed to be
language of
included.
multiple healthcare providers with prescriptive authority. So it doesn't have to just be between one and one. It's not a one-to-one ratio. It can be a group of pharmacists and a group of physicians or a group of healthcare practitioners. Yes.
Okay, I need a clarification from the lawyers. Since that was a committee motion, if you want to change it, don't you have to make the motion?
No, this wasn't, the
and vote
committee
it
directed
down?
the staff to create this language. So I
Oh.
think that we need a new motion, a motion to accept this language, because we've never seen this language.
Oh, okay.
Right. There was discussion about which term should be included, and the motion was to direct staff to work with legal
Okay.
to come up with the text.
Okay.
The committee members, Ellen, Cheryl, or Albert, if you guys want to make a motion for this, if you're okay with this language that Kelsey provided.
I so move.
Motion
Cheryl, would
by
you like a
Alan,
second?
A second.
Okay.
second by Cheryl. Any further comments from board members? Public comments? Steve?
Steve Gray is an individual pharmacist. First of all, I support the motion wholeheartedly, and I want to give you a little bit of background. This has actually been what we've been doing for 30 years. 30 years. 405 2.1, as Maria indicated, allows the hospital entity to grant the authority to initiate, adjust, et cetera. But everybody knew that was through the medical staff. And that was a medical staff privilege. The medical staff granted privileges in the hospital. Medical staff presidents are physicians, et cetera. 405 2.2 took that as it evolved after it was proven safe, effective, and highly improved medical care with bridge treatment for warfarin treatment and other things as the patient was leaving the hospital. 405 2.2 then evolved, and that has been continually evolving to where it is. And there are large medical groups that, in fact, have regional protocols adopted by the medical group corporation or the medical group partnership that give the pharmacists, usually a pharmacist service, meaning several pharmacists, the authority to manage patients, that they have authorized to manage. So this has a lot of proven history of being highly valuable, highly safe, and in fact, would almost be negligent not to go forward with this. And if you think about it, the interpretations that have been applied and tested through the Attorney General's office have indicated that since nurse practitioners and others are under the supervision of a physician, a medical group, that the referrals of patients can also come from them through that delegated authority. And that's exactly what we want, because the nurse practitioners said, look, I'm taking care of these patients, but when it gets to the point where the prescription therapy is more complicated, or the patient is more complicated, I need to have a medication specialist take over this and help me with these patients. And so a lot of the referrals come from primary care physicians or other primary care providers to where it gets to be a complicated patient or a high-risk drug or a complicated patient for behavioral reasons, then those are the ones that pharmacists are taking care of. And this is also recognized by the federal government in that the prescriptions issued by these California pharmacists are recognized and honored under Medicare Part D. which, as you know, is seniors and is more likely to be complicated drug therapies, multiple drugs, et cetera, patients with gradually failing internal systems and so forth. How much so? In 2013, Medicare Part D, I know from one organization, 2,000 pharmacists issued over almost 300,000 Medicare Part D covered prescriptions for 65 to 68,000 Medicare patients. And they're all paid for by the federal government, and they're all considered legitimate prescriptions, and they go through the process with the pharmacist being listed as the prescriber, just like any ordinary prescription. Now what has happened, that has been a model for the rest of the country, and I think what part of this was based on was the report from the National Alliance of State Pharmacy Associations, where they did an analysis, and what they said was some states have had very limited collaborative drug therapy statutes, regulations, and understandings, and they were recommending that every state take a look at theirs and gradually, now that this is so well proven, we have collaborative drug therapy management in at least 49 of the 50 states in a significant way. I think one of the last ones to join was New York, actually. And so it's well practiced, and it even, in some states, it has even gone farther than in California, for an example, Washington State and so forth.
Yeah.
So I just wanted to provide a lot of encouragement for supporting this. Thank you.
Yeah, I just want to kind of add what our goal is here is to push this beyond right now healthcare facilities and home health care agencies, licensed clinic, kind of really push it out to, to even like the retail pharmacies. I know in Southern California, we have a couple of health plans that have asked the pharmacists to go out and secure collaborative practice agreements with the physicians in the area so that they can better manage the patient and hit some quality targets. And just as a reminder, a collaborative practice agreement is an agreement between a pharmacist or pharmacists, multiple pharmacists, and a prescriber or multiple prescribers. And what's allowed is an agreement between them. So what what the prescriber is comfortable with is what the pharmacist can do. So there's not like like a state protocol where they all operate this way. It's an agreement between the two. So whatever that prescriber is used to. And when I look back, and I remember when vaccinations first, pharmacists were first getting involved in vaccinations, that's what we had, is we had a agreement with the prescriber to do flu shots or whatever for, in my case, a group of retail stores, and how we manage that depended on, an agreement between us and the prescriber. So this isn't new stuff, but it is ability to kind of move forward and, hit a lot of the quality things that we've been asked to do.
Okay, Samantha?
Thank you. Samantha Payon, California Medical Association. The proposal to allow the initiation, adjustment, or discontinue of drug therapy is also a concern for us, in that it would allow for a medical director of a retail pharmacy to sign an agreement, allowing for multiple pharmacists to essentially prescribe medication. Not only does this raise concerns, patient safety concerns, but it also disrupts and fragments patient care. And this, and I know we're going to talk about it next, but combined with the deletion of the reference to section 405.2.2a, removes crucial oversight and mechanisms that were put in place to ensure that there's coordinated care between a patient's treating physician and the pharmacist. As such, we do have concerns that the proposed expansion could have a negative impact on patient safety by increasing fragmentization in the delivery of medical care, as well as authorized primary care delivery by practitioners who may lack the requisite education training experience. Again, we welcome the opportunity to have further discussions regarding this proposal and the next one that will be up for consideration.
So I want to make sure you understand with collaborative practice that if a doctor's not comfortable with a pharmacist to operate under his or her rules and guidelines, which would probably mean if Maria came into my pharmacy and I'm going to treat her, and the doctor if Maria comes in, you have to tell me about it, and you can only treat her for these 5 things, that's all part of the agreement.
I just wanted to clarify with you is that this is not an expansion because it's current regulation that these functions are allowed in many of our settings already. And then again, it is essentially a recipe. It's not an approval for prescribing. It's the physician has said, I want you to treat this patient with this drug, go for it kind of thing, with a recipe. So it's not independent practice at all. It's all with the physician's oversight and understanding and approval.
Sure, but I think as currently worded, it does say any healthcare practitioner with prescriber authority. So that is, in terms of keeping monitoring and tracking of these patients, that could be a concern. And then also the initiation is different, as I understand it, from
The physician
previous.
initiates the protocol. So the physician, it all starts with a physician order. The physician always initiates the protocol.
But it says to initiate
and then
adjust.
and once they initiate the protocol is and we could talk about this maybe offline to help alleviate some of your concerns.
Mhm.
But with any physician or any healthcare provider, that just means that the healthcare provider and the pharmacist can come into a agreement.
Mm.
It does not mean that any provider is forced to follow that agreement.
Sure.
You're not forced to. It's the physician is in total control.
Yeah, and maybe we can talk more about this offline, but I think to some degree, this is still going to be a concern in terms of the ongoing monitoring and especially with particular complex conditions. So
Probably if it's a super complex condition, it might not be part of the protocol.
Right.
Because what would be in the protocol would be, what conditions would be listed in the protocol.
To alleviate some of your concerns is that, in practicality and reality, how patients are cared for, if the protocol is not specific enough for that patient, the pharmacist cannot make any independent judgment. They always have to call the physician and have a discussion as to why we cannot follow the protocol or why this patient doesn't fit the criteria of the protocol. The physician is always in charge. The protocol just allows the pharmacist to abide by the decisions already made by the physician.
right.
And if the patient doesn't qualify, then the protocol is no longer valid.
And maybe depending on the setting, I think the setting will also determine whether or not that's going to be an avenue to engage upon if it's a CBA. But like I said, I think we could have further conversations about what that is. And I don't know that the CBs are actually defined in statute. Are they? Okay.
It's very, very specific.
I don't know, Anne, is there can you or someone from the staff reach out to CMA and help them understand and refer maybe to our statute?
I think we understand what CBAs are. I think where the concerns are in terms of fragmentation of care, and that's going to be across settings, whether it's the retail pharmacy environment. There may be some concerns about that.
I think not to oversimplify, I think that they just don't agree with the policy direction of the board. So I'm happy to have conversation, but I think that it's a policy difference in where you think patient care and what pharmacists can do and their position. I'm not trying to oversimplify, but I think at the end of the day, that's what it is.
Okay.
All right, thank you. Any other public comments? If not, let's call for the vote. All those in favor, please raise your hand. Oppose, abstain, and motion carry. Debbie, any more?
And an attachment 2 is, I referenced the NASB report a couple of times because it was kind of one of the key things we looked at, and that is included in attachment 2. So one of the things we are required to do is have a post-implementation review of the Advanced Practice Pharmacist Licensing Program, including the licensing requirements and functions authorized. So 4210 establishes the requirements for an individual to qualify for recognition as advanced practice pharmacist, and 4052.6 identifies the privileges of an advanced practice pharmacist. Title 1730.1 defines the application requirements for advanced practice pharmacists. I'm not going to go through what these, 4052 and 4210, as we've gone over those details in the past. But at a staff level, changes have been made to the application process to minimize deficiencies. For example, one of the most common deficiencies initially encountered was the required documentation to satisfy the qualifying criteria of experience under the collaborative practice agreement or protocol. In response to this common deficiency, the board developed an affidavit that could be used, and that could be completed and signed by both the applicant and the supervising practitioner, program director, or health facility administrator to satisfy these required statements. Because as I remember, people were just having problems with me finding the piece of paper or some sort of document that would prove it. So we created an affidavit that could be used. And the affidavit had specific language attesting under the penalty of perjury. These changes have reduced the deficiency rate, but unfortunately, some applicants continue to submit affidavits without the signatures. Board staff will continue to amend the instructions for clarity. Another implementation challenge is double dipping, which is encountered when an applicant wishes to apply the residency requirement to fulfill both pathway as well as certification pathway. And in such cases, the applicant must complete a second criterion, which is typically the collaborative practice experience pathway. In this instance, the board allows the applicant 1 year to satisfy one of the other criterion to complete the pathway, thus keeping the application in pending status. As of March 2019, there were 57 applications pending where the experience conflict was deficient in the application. So I know I just kind of squirted over it, but I'll just kind of reiterate what the 2 of the 3 following pathways have to be completed. One is earn a certification in a relevant area of practice. Second is completion of a postgraduate residency. And third is clinical experience for at least 1 year under the collaborative practice agreement or protocol. And Ann, you can correct me, but I believe when the most common double dipping we see is when someone completes a postgraduate residency, they use that year or multiple years in their residency to not only check the box for the postgraduate residency, but also to check the box for the 1 year of experience. Is that correct? The staff also notes that individuals are completing certification programs that do not satisfy the requirements established. Regrettably, denial of the certification program results in the applicant having to qualify via another certification or another one of the qualifying criteria. On February 9, 2017, we issued our first APHA license. And as of March 31, 2019, the board has issued a total of 515 APH license. The board has received 190 APH applications this fiscal year and has 179 of those pending. So that sounds like a high pending percent. Can you give us any color to that? Okay.
I think that so some of when the double dipping challenges that when people have to go back, we leave them in a pending status typically so that they can fulfill the other one and not have to reapply in those pending.
So that was 57 of them, right?
I would have to get the exact number of those that are currently stuck in that.
During the April committee meeting, Dr. Joe Guglielmo, Guglielmo, who is the Dean of the University of California, San Francisco, shared with the members that he supports the committee in their efforts to review the criteria of the APH license and the collaborative practice agreement. The committee discussed the authority of an advanced practice pharmacist as defined in 4052.6 and possible ways to expand the authority beyond that of a licensed pharmacist, as well as proposed changes to the language. The committee discussed the licensing requirement under 4210A2, which requires a person to satisfy the 2 of the 3 criteria in order to qualify. The committee agreed, based on public comment, that this section of the law needs to be revisited by the licensing committee to ensure that the requirements align with the scope of practice of an APH. So the committee, just one sec. So the committee motion is to recommend to the board to consider directing the licensing committee to assess the requirements in 4210 to qualify for an APHA license to bring it in scope of practice.
You know, one of the, during his presentation, he presented a paper that he and the dean of the Washington School of Pharmacy wrote together. And the requirements for what we consider advanced practice and Washington's requirements differ considerably, with Washington's being much less restrictive than ours. Of course, our political situation is different here in California, but it's informative reading and can give some scope to the license to the licensee members.
All right, this is the committee recommendation. Is there any comments from board members? Public comments? If not, all those in favor, please raise.
Wait, we got a comment.
There's one? Okay. Coming up. Coming up.
Just stay up here. Samantha Paone, CMA, just for the reasons stated before that we do have concerns about removing this provision because it ties it back to the treating prescriber, and not really sure what the justification was in making that recommendation. Thank you.
I think, so stay there, because I haven't made that motion yet.
Oh.
It was out of order. It was out of order in our notes. So actually, I made the motion that we're just looking at the requirements.
My
And then in a
apologies.
minute, we're going to go to the one where we remove that, I think the piece that you're talking about, right?
Oh, yes.
Okay. So stay right there, and then you can make your
Apologies.
discussion.
Danny, do you have something else?
So this is to recommend that we're going to reassess the requirements of 4210, what to qualify for an APH license.
This is on the
Top of page 7.
yes, CPHA supports that. Thank you.
Okay. Any other public comments? Steve?
Steve Gray is an individual pharmacist. I support the motion. I was there at the licensing committee and heard all of the discussion, and it was very well handled. What I would like to emphasize is, and encourage you to think about in support of the motion, I was very much involved. I can't overemphasize how much I was involved in SB 493 and that whole creation of the advanced practice license category. When we were looking at what it would take for a pharmacist that should have, governing our profession, being honest with ourselves, we said they need to have the proper education, they need to have the proper training, and they need to have the proper experience. You can only get so much out of education, only get so much out of training, and you need to have some actual practice experience. And then when they came up with, well, you need to have different pathways to get there, because one, there was actually a decrease in residency programs going through. If you look at the economic downturn, hospitals and others were actually decreasing the number of residents and so forth that they were producing. So how do you get there? How do you get to this ability to take care of the patients with pharmacists' extensive knowledge in medication therapy? And so we created the advanced practice pharmacist category, and we said, yeah, 2 out of the 3. But it was always the intent. It was always the intent of the senator and the 2 associations that sponsored the bill and worked very, very closely together, that you could get the education, you can get the training, and you can get the experience, and that's what mattered. So if, and then it would later, someone came along and said, well, wait a minute, that's double dipping. No, that wasn't the intent at all. That if you went through the first one, which is certification by the National Recognized Board of Pharmacy Specialties, there's like, in some of those, there's like multiple years of experience before they'll give you the certification. It's more than just the education and training. That's wrapped into experience. When you look at a residency program, a clinical residency program under 405 again, which has been the law for over 25 years, in that clinical postgraduate clinical residency program, nationally accredited, there is experience, more than 1,000 hours in working with experienced and oversight to initiate, adjust, and discontinue prescription medication therapy, including recognized by the Drug Enforcement Administration as a mid-level practitioner without any restrictions on which schedules of controlled substances, if that's what your protocol said you could do, right? And then the last category there of it was, well, what if there isn't enough certification programs? What if there isn't enough residency programs? And that's when we added the third one, which is to say you could work under the mentorship, close guidance of a physician, another advanced practice pharmacist, or a collaborative drug therapy residency trained. And so that was the intent. And so what I took the meaning of the licensing committee and congratulate them on is, let's take a look at this issue of double dipping and let's rethink that. Because if they're meeting the basic requirements of enough education, enough training, and enough experience, then it really doesn't matter whether you get them all at once or not, such as you would get in a nationally accredited Board of Pharmacy Specialist training programs, which often, as I said, takes multiple years of experience. And I just want to encourage you to go forward with this. Thank you.
Yeah, thanks. That was a good summary. Good history lesson.
Any other public comments? Okay, so
We have a-
Samantha, do you want to adjust?
No, we
the-
vote. She wants it. Our next motion, she
The
wants to
next
talk
one.
about.
Okay, so not this one. All right, let's call for the vote then. All those in favor, please raise your hand. Oppose, abstain, and the motion carry.
Okay, so the next motion by the committee was when we were looking at advanced practice pharmacists and what we were recommending with collaborative practice. We felt like after looking at what advanced practice pharmacists, the requirements that they would actually have the ability to do maybe a little bit more than what is in 4052.6. So we're recommending under 4052.6 deletion of one part of a sentence. So I'm just going to read the first 5 requirements here and then highlight the sentence that would be deleted. A pharmacist recognized by the board as advanced practice pharmacist may do all the following. Number 1, perform patient assessment. Number 2, order and interpret drug therapy related tests. Number 3, refer patients to other healthcare providers. Number 4, participate in the evaluation and management of diseases and health conditions in collaboration with other healthcare providers. Number 5, initiate, adjust, or discontinue drug therapy in the manner specified in paragraph 4 of subdivision 4052.2, which is the collaborative practice agreement section that we just were talking about in the prior agenda item. So what we were recommending is that on item number 5 for advanced practice pharmacists only, that initiate, adjust, or discontinue drug therapy, period, that it would not have to be in a manner specified in 4052.2. They're already working with other healthcare providers, and basically we're recommending that perhaps they don't have to have a collaborative practice agreement in place.
Thank you. Samantha Payon, California Medical Association. And I would just state that we are opposed to removing that language. I think the language was specifically put in there to ensure that there is proper coordination of care between healthcare providers, and that by removing so, it would potentially harm that. So, thank you.
And actually, I handed it over to her before I said what our motion was. Our motion was recommend to the board to amend 4052.6A5 to remove in the manner specified in paragraph 4 after initiate, adjust, and discontinue.
Okay, any other public comments? Steve?
Steve Gray, again, is an individual pharmacist. With collaborative practice, whether as it was initially in the hospital, of course, it was all under a group practice. It was all, pharmacists could not admit patients to the hospital. Pharmacists don't diagnose patients, but they work with the medical staff and the attending physicians and others to take care of the patient's medication therapy. And they do that by the either the attending physician or other admitting party saying, take care of this patient for me. I mean, that's as simple as it is. And under the policies and procedures of the hospital, they go forward. Outside the hospital, we had 405 2.2, and there is no medical staff in the outside world. And so it does take a referral. And I think this is where I'm kind of disagreeing with what's been put before you. I think that by removing the reference to 405 2.2 paragraph 4, you've really kind of removed the concept, as was stated, of a referral from a person who can diagnose and who is treating the patient. And I think that language needs to be reconsidered. I know that phrase per section 405.2 paragraph 4 was put in at the last minute in 405 2.6 just because there was sought to be a confusion about, is the pharmacist still working only with a referral, only with authorization from a prescriber, or is the pharmacist working independent? And I testified before the medical board on this. I testified before the CAPG committee, California Association of Physician Groups, and I met with the leadership of California Medical Association. And we assured all of them to get their support. We got full support of the medical board, full support of CAPG, and neutral from oppose from the California Medical Association, because we assured them that pharmacists were not independent prescribers and treaters. They took referred patients from prescribers. Pharmacists do not diagnose. They're not primary care, because primary care in the other professions means that's the person who diagnoses. And pharmacists are not trained to diagnose. They don't get years of differential diagnosis training like physicians and others do, or even get it to the point probably where nurse practitioners do. But they can take referrals, as I mentioned earlier today, when those practitioners say, I need the help of a pharmacist on this, and we want you to help and take over this. So I would recommend that you not approve this language, send it back for some reconsideration of how do we go where we want to go, but make sure that it's clear that pharmacists are still working only after there is a referral from a prescriber, as we talked about earlier. Thank you.
I just want to point out, just for clarity, that if you continue reading on in this section, and the next, that was A. B is the pharmacist who adjusts or discontinue drug therapy shall promptly transmit written notification to the patient's diagnosing prescriber or enter the appropriate information in the patient healthcare record shared by the prescriber as permitted by that prescriber. Pharmacist who initiates drug therapy shall promptly transmit written notification to or enter the appropriate information into patient record system shared by the primary care. The section shall not interfere with physician's order to dispense prescriptions as written. D, prior to initiating or adjusting a controlled substance, pharmacists shall be registered with DEA. And E, a pharmacist who orders and interprets tests pursuant to paragraph 2 of subdivision A shall ensure that the ordering of those tests are done in coordination with the primary care provider or diagnosing prescriber as appropriate, including promptly transmitting written notification to the patient's diagnosing prescriber or entering the appropriate information in the patient record shared by the prescriber when available and permitted by that prescriber. So I actually think that it's already in there, that we have to stay coordinated with the prescriber, that we aren't cowboys out there, doing something on our own.
Right, and I agree with what you read, but the way that is stated is after the fact. It's after I've done this as an advanced practice pharmacist. Now I've initiated a prescription, and I'm going to tell them after the fact what we did. It's not clear without that language about reference back to 405 2.2 that it took a collaborative agreement or a referral in the first place. Now, maybe that's not your intention, but I think that's where the confusion lies. And it was our intent in SB 493 to still require, it be part of a group practice with other practitioners, and they still take a referral and have a protocol.
Well, I mean, the section right before what we're removing says that you have to participate in evaluation and management in collaboration with the other healthcare providers.
And I guess that's kind of broad, and it doesn't really say, like the 4052 says, that you've gotten an order or an authorization from the prescriber to go ahead with the protocol. So I think that may be your intent. I'm just saying I can see where the confusion may lie, and I think the wording can be adjusted. Because I'll be very honest with you, that phrase was put in there in the 11th hour and 59 minutes of the legislative session to address some of the concerns that we heard the CMA representative talk about.
Well, I think we also feel like the advanced practice pharmacist operates at a higher level, and that that's why we don't need to point back to the 4052.2.
Thank you.
Yes, Danny.
And with all due respect to Dr. Gray, I have the utmost respect for his knowledge and wisdom. I also want to echo that the advanced practice pharmacist is not meant to be the regular pharmacist. And I'll actually do a little reading myself. Section 4210, which describes advanced practice pharmacist license and what it takes to actually become an advanced practice pharmacist. And in there, we're talking, and again, respect to CMA. A lot of their opposition to these policies have to do with, their perceived lack of training or education. I'll just read here, subsection A2A, earn certification in a relevant area of practice, including but not limited to ambulatory care, critical care, geriatric pharmacy, nuclear pharmacy, nutrition support pharmacy, oncology pharmacy, pediatric pharmacotherapy, or psychiatric pharmacy from an organization accredited by ACPE or other entity recognized by the board. Following down, complete a postgraduate residency through an accredited postgraduate institution where at least 50% of the experience comes from the provision of direct patient care services with interdisciplinary teams. Having said all that, we absolutely support this motion and would ask for your support.
Mr. President, members of the board, I was going to stay quiet on this, but after Dr. Gray's presentation, I had to stand up and say there's 10 states that allow population-based collaborative practice agreements where there is no referral. Washington's allowed it for 40 years. They have 30,000 collaborative practice agreements with pharmacists that don't get referrals from doctors. Idaho's allowed it since 1999. There's 2 states that allow pharmacists independent prescriptive authority. It is limited to minor ailments and conditions. There's other certain limitations like no controlled substances. But this idea that pharmacists can't diagnose, I think, is old school, incorrect. We're not talking about diagnosing complex cancer here. You certainly can diagnose a strep throat pursuant to a collaborative practice agreement that's population-based without a referral. It's been done for decades in states like Wisconsin and Michigan and Washington and Idaho. It's proven true. The states that I mentioned are obviously Idaho, that has prescriptive authority, Oregon, and this week in Rhode Island, they will be considering the exact same Idaho language that gives pharmacists prescriptive authority for those minor ailments and conditions. It's the movement that I think California is trying to get on the cusp of and make up for years of being behind. I don't think it's this like crazy practice that everybody's making it out to be.
So we're not cutting edge is what you're telling me?
Not on this subject, but you will be after one more motion.
Here's the question to Laura. So does this need a statutory change, or just something that we propose it and then we'll need a statutory change to this amendment, right? So all we're just proposing to do it, but it has to be done in the future. Is that right?
Correct. The board would have to find an author, and then it would go through the legislative process.
Okay, but it's just something we propose to change.
Correct.
Right. Any other public comments? If not, let's call for the vote. All those in favor of the committee recommendation, please raise your hand. Oppose, abstain, and the motion carry.
All right, thank you. Moving on to agenda item D, discussion and consideration of the current provision of pharmacy law governing board licensed facilities either impacted by a declared disaster or otherwise destroyed. Relevant law of 4062C specifies during a declared federal, state, or local emergency, the board shall allow for the employment of a mobile pharmacy or clinic in the impacted area in order to ensure the continuity of patient care. 4201F specifies, notwithstanding any other law, the pharmacy license shall authorize the holder to conduct a pharmacy. The license shall be renewed annually and shall not be transferable. During December 2018, the committee meeting, members discussed the impact of the recent declared emergency disasters which had pharmacies licensed by the board. During the most recent declared emergency resulting in the Camp Fire, 5 pharmacies were closed because of the business either burned down or sustained significant fire damage, and 1 wholesaler facility was destroyed. This resulted in facilities having to secure a mobile pharmacy or relocate to another area. Currently, 4062 only allows for the pharmacy or clinic to employ a mobile pharmacy in the impacted areas. The pharmacy or the clinic relocates to another location in the impacted areas of the emergency area or surrounding area that is not a mobile pharmacy. That means the license has to be transferred. And another key point, I think, is you can only operate the mobile pharmacy while it's a declared disaster. And that's correct, right? You can only operate the mobile pharmacy while it's a declared disaster. You might want to turn on your microphone.
And then for a period of time afterwards, I'm thinking it's 120 days or something.
Okay. So although mobile pharmacy sounds like a great solution, there's just a finite period of time that you can operate that pharmacy. So during our meeting, we have a pharmacist, excuse me, who's the owner of 2 pharmacies impacted by the Camp Fire. And I'll let her come up and say a couple words. But she personally, found herself in the situation where her pharmacy is burned down. She's wanting to relocate to another, excuse me, location, but that's a transfer of a pharmacy. So she wasn't moving to a mobile pharmacy, she was moving to a new site. So that was a transfer of pharmacy. She'd have to go through the relicensing process and then, get a new, I think maybe a new Medi-Cal license and re-sign some contracts with the with some of the payers. So anyway, she found a lot of barriers. So maybe to save me from coughing to death here, Dr. Hohenbanner? Okay, why don't you come on up and tell us what you experienced.
To clarify, so they can use the mobile trailer for 48 hours, but the board can extend that to 90 days. Sorry.
Thank you.
Hi, my name is Lisa Hohentanner. I'm a pharmacist. We had 2 pharmacies that were impacted by the Camp Fire up in Northern California. Since that time, we've found some challenges in getting back open so that we can get back to taking care of our patients. As you guys know, the current law does not allow for a pharmacy license to be transferable. So basically, I'm here to advocate for a change in the existing law to allow a pharmacy to relocate in a disaster situation.
Thank you.
Okay, so if you look, we made the motion to update the language to an urgency clause, but we asked the staff to refine it. So I think we will need a motion in a second because we have not seen this language. But basically what is being suggested under 4062, that we will add Section E, a pharmacy destroyed or damaged either as a result of a declared state, federal, or local emergency or otherwise destroyed by natural disaster may be relocated. Such a relocation shall not be considered transferred if no changes are made to the management and control or the ownership of the pharmacy. Notification of such relocation must be made to the board immediately upon identifying the new location. So does one of the committee members want to make that motion to move forward with that language?
I
I'm
would-
sure it's a statutory change, right, Ann?
I would motion to so.
All right, moved by Cheryl
I
and
second it.
second by Albert. Any other comments from board members?
Does that motion include advocating for urgency? Because I think that that's,
Thank you very much. I did miss that. We are advocating for emergency.
Yes, we are advocating for emergency. That is my motion.
All right, and you okay with that, Albert?
Yes.
Second by Albert. All right, public comments?
Because we're hoping, should we have another emergency next year, that we'll already have this in place.
CPHA wholeheartedly supports this. Dr. Hohen-Tanner is a member of ours, and part of our legislative committee brought this to our attention, and we're happy that the board's considering this, so we ask for your support.
Thank you. Any other public comments? If not, let's call for the vote. All those in favor, please raise your hand. Unanimous? Okay, motion carry.
Thank you. Moving on to section or number E, discussion and consideration of proposed language establishing parameters and fees for inspection of sterile compounding pharmacies as a result of remodeling. So recent law establishes the authority to inspect a sterile compounding pharmacy and specifies a license to compound sterile drug products shall not be issued or renewed until the location is inspected by the board and found in compliance. 4127-2 establishes similar authority for non-resident sterile compounding pharmacies. During the December 2018 Pharmacy Committee meeting, members discussed the requirements of inspecting a sterile compounding pharmacy at the time of issuance and renewal, as well as the need to perform inspection of sterile compounding pharmacies due to remodel. The committee considered whether to assess a new inspection fee if the inspection occurs outside the parameters of the mandated renewal inspection. The board is mandated to ensure sterile compounding pharmacies are in compliance with pharmacy law. An inspection at the conclusion of the remodel is necessary to ensure that changes to the sterile compounding pharmacy as a result of a remodel do not pose any safety concerns to the consumers. Currently, the board does not have the authority to require notification of, nor assess a fee for the inspection as a result of the remodel. Currently, when the board is notified of a remodel, the board makes every effort to conduct the inspection as part of the mandated renewal inspection. However, the remodel concludes outside the typical time frame for renewal inspection. The board currently absorbs the cost, which impacts our budget. The board must immediately respond to perform such remodel inspection because a delay could impact patient care. During the December 2018 meeting, remodels vary in scope from simple to full remodel or expansion, and there are several reasons that a remodel may trigger an inspection, such as unforeseen damage, planned upgrades, and expansion. Additional discussion included establishment of the following parameters to determine if a remodel of a sterile compounding pharmacy required an inspection and to assess if an inspection fee is required. Require the remodel notification application prior to the conclusion of a remodel to collect the anticipated completion date and identify what is impacted by the remodel for the board to determine if an inspection is required. And this actually came out of quite a bit of discussion from the public that, you know, the remodel could be a wide variety of things. And sometimes the board may decide that the remodel does not need to be re-inspected. Or maybe there's a remodel that the licensee thinks perhaps doesn't need to be re-inspected, but we think it's a major thing. So it's, you know, it's communication. Number 2, the board to notify the sterile compounding pharmacy if the remodel impacts patient care in a manner that would result in an inspection of the pharmacy. So we would notify the licensee. Assess an inspection fee if the remodel concludes more than 90 days prior to the expiration date of the license, and if the remodel concludes within the 90 days prior to the expiration date, then the inspection would be would serve as also the renewal inspection, so we would waive the fee. We felt that we this would help motivate people to notify us, and we already are currently bending over backwards to make sure that we get out there as soon as we can so that we don't impact patient care, but that we felt in many cases we could align the reinspection, the renewal inspection, and the reinspection of the remodel at the same time. Further, as part of the proposed revision to USP 797, the standards provided that recertification of a classified area must occur if there are changes to the area such as redesign, construction, or replacement or relocation of any PEC, or alteration in the configuration of the room that would affect airflow or air quality. Alignment with such a requirement appears to be appropriate. So the committee discussed the board's mandate to inspect the facility to ensure compliance with the conclusion of the remodel, as well as addressing the concerns received by the public regarding charging a fee for inspection outside the renewal period. After receiving additional public comment, the committee proposed moving forward with the accepting the proposed language as written, which includes charging a fee if the facility is unable to coordinate the completion of the construction with the renewal inspection. And additionally, the committee also agreed that non-resident sterile compounding facilities would need to pay for the cost of travel for the board inspectors to conduct the inspection. So we had, I think at advice of counsel, we divided this into 2 motions. The first being approved the proposed language in 4400 to assess a remodel inspection fee for in-state sterile compounding pharmacies, and to assess the remodel inspection fee and travel costs for out-of-state sterile compounding pharmacies, and direct staff to work with counsel to finalize the language. Oh, so I was thinking we had it. So let me read the final language. So we added to 4400U, the fee for inspection of a remodeled pharmacy shall be $780. And to V, the fee for inspection of a remodeled facility shall be $780. In addition to paying the remodel inspection fee, the non-resident sterile compounding pharmacy shall deposit, when requested by the board, following receipt of a remodel notification, a reasonable amount as determined by the board necessary to cover the board's estimated costs of performing the inspection required by section 4127.5. If the required deposit is not submitted, the remodel notification will be deemed to be incomplete. If the actual cost of the inspection exceeds the amount deposited, the board shall provide to the applicant a written invoice for the remaining amount, and any remaining outstanding balance will be added to renewal costs. So, I guess we didn't have this language at the time. Did we have this? Did we have this language at the time of the meeting?
You do?
I guess to be safe, let's just have the committee members. Do you want to propose
Motion.
acceptance of this language?
Moved by Alan.
Do we have a second? Albert, second.
Albert, second by Albert. Any other comments from board members? Public comments? Seeing none, let's call for the vote. All those in favor, please raise your hand. Unanimous? Okay, motion is carried.
Okay, and then our second motion was approve the language as proposed and seek legislation to add 4127.5, which I think the staff wrote, and it says a pharmacy license pursuant to 4127.1 or 4127.2 must notify the board of its intention to remodel a facility within 30 days of initiation of the remodel. As part of the notification, the licensee must provide the anticipated date of completion and the provisions for patient care during the remodel. For any remodel that results in recertification of an ISO classified area under USP 797, the board must perform an inspection to confirm compliance with this article and regulations approved by the board prior to the resumption of sterile compounding within the facility. When possible, the board will conduct the inspection within the preceding 90 days of the renewal of the license. In such instances, a remodel inspection fee shall not be required. So I think, let's go ahead and make that a motion.
All right, and that's the committee recommendation. Any other comments
I'm
from
not
board members?
positive we have this language, so let's
Yeah.
go
You
ahead
have
and
the
just make it a
language?
motion.
Also, I so move.
It's moved by Alan. Second by Cheryl. Any other comments from board members? Public comments? Danny?
I have a clarification question. So, in an instance where you cannot physically coordinate with the remodel, with the regular renewal, I should say, this is proposing to charge us $785, I think is what the fee is. So, in other words, let's say I just renewed my license, and a drunk driver plows into my pharmacy and destroys it. Clearly, I cannot at that point coordinate within the preceding 90 days in order to get this fee waived. So am I correct in assuming that in that instance, I would still be required to pay this fee?
We can exempt that instance.
Well, I mean, so I guess I'm trying to say is if I'm a pharmacist who's trying to coordinate, because obviously I don't want to pay unnecessary fees if I don't have to. But in this case, it's impossible to coordinate that unless I'd wait 2 years and essentially not run the pharmacy for 2 years in order to coordinate for my next renewal. So you understand what I'm saying?
Yeah.
So I guess I'm wondering, was that the intent for instances that are clearly outside the?
We did not address exceptions like that.
Okay. Well, I would ask that this board. I understand you have a motion in a second. I would ask this board to think about that. There are those instances where something beyond the control of unforeseen circumstances, and I don't believe it's fair to charge a fee for something that was completely out of their control. Perhaps you could add an exception for such instances.
Where you're asking for this, are you asking for it specific for just resident, or are you also asking for non-resident pharmacies?
Well, I guess I would ask for resident because I'm talking specifically in California. So,
That was my
yeah.
Right,
So
Steve?
that would actually be amending the motion we just passed.
Well, you haven't, I don't think you voted, right?
Because we did the fees a minute ago, and I think that's what he wants.
Yes, Steve.
Yeah, Steve
Go
Gray, speaking as a pharmacist. I remember it a little different at the licensing committee meeting. I remember there was discussion, and it wasn't just at one committee meeting. This has been on the agenda for several times. That the idea was to notify the board if you intend to remodel. The board, and you're going to describe what the remodel is.
Right.
And then the board would decide whether an inspection was necessary or not, depending upon the scope of the remodel. And then someone added, well, if it involves, as the motion says, the ISO, then it has to be. But it looks to me like the language almost assumes that the board will always require an inspection for any type of remodel. And I don't think that was the nature of the discussion. I thought that the idea was, you let us know what you're going to remodel. We may decide that an inspection is not necessary, and then therefore, you won't have to pay the fee. So I think it's a little different than what I'd heard the concept before.
Can I just add, because it says for any remodel that results in recertification of ISO classified areas, and I thought that's what we defined, and as that would be our definition of what needed to be re-inspected.
And just that. So anything that doesn't require recertification then would not require an inspection or a fee.
I think that's correct, right, Ann?
So I think what we're trying to do is harmonize with 797, and so that's what the policy direction was.
Okay, because there are remodels that can affect, without affecting the certification of the ISO area, but there are remodels such as to the anteroom area, to other things that may affect the safety of the pharmacy, that you may want to say we need to re-inspect. So all I'm saying is that I didn't remember that the limitation was only if it caused a recertification of the ISO area. So I'm just trying to get to kind of rethink what this was.
So just to clarify, the language that is in the packet is the language that was considered by the committee.
Okay.
Okay.
And then the second thing that would cause confusion, because two people asked me this.
Can I just clarify? So when I read USP 797, says that it has to be recertified. A classified area must occur if there are changes to the area such as redesign, construction, or replacement or relocation of any PEC or any alteration in the configuration of the room that could affect air quality, airflow, or air quality.
That's what 797 says?
Yeah.
Then why
That's what we're referring to. Once again, I'll defer to Ann, but she's probably a little smarter on this than me. But when we say ISO classified area, that's what we're referring to.
Okay. If I guess it would be clearer if you just use that language.
What if it changes, I guess?
Right. So again, we're trying to harmonize with USP and reference USP. That's kind of the policy direction that the board's been going with.
Right.
So that's what the language was built upon.
Okay. Then the second thing is the 30 days notice. Is that 30 days before the remodel starts, or 30
within
days
30
after?
days of initiation of the remodel.
That's what I'm asking. Is that the of? Does it mean 30 days before or 30 days after?
After.
Okay. Just for clarification, you might want to, again, several people have asked that because there was discussion about having to notify the board before you started the remodel. So if you could change that word to after, then it's clear.
What do you guys think? Law degree individuals?
I don't find any lack of clarity in within 30 days of, but the board can make its own conclusions about that.
Okay, so. Okay.
So we're okay? We don't need any
Yeah,
other?
we're okay with it.
Yeah, we're okay with it? Okay. All right. Any other comments from board members? Public comments? If not, let's call for the vote. All those in favor, please raise your hand. Unanimous? Okay, motion's carried.
Okay, licensing statistics. You picked up your little blue copy out there. I think, did we print these for everybody? Yeah, there's some in the back. You want to see the most recent licensing statistics? It's riveting information. You might need reading glasses. But it's the statistics for July 1st, 2008, which is when our fiscal year starts, through March 31st, 2019, so probably the most recent cutoff we could do. And it's been updated to include discontinuance of business by date of closure. Our committee member, Dr. Albert Wong, asked for that to be included, and we thought that would be an interesting piece of information. So if you look at March 31st, 2019, you'll see all the initial applications, and I did look that up, and from January 1st, 2018 through March 31st, 2019, there were 357 pharmacies that were that had a date of closure that were closed, basically closed for business. I'm probably not going to go through any of the other numbers. I'll let you read through. Processing times, the general application deficiency mail processing times by license type are provided in the packet and are current as of April 19th. The data reflects the time from when an application or deficiency response is received by the board through the time it is processed by licensing staff. Currently, the majority of initial applications are being processed within the board's 30-day performance standard, and the board is currently outside the 10-day processing time for deficiency mail for a number of application types. It is anticipated that the 2 vacant positions will be filled on or about July 1st, which should assist in further improving the processing times. But overall, the processing times are pretty darn good. And we've really made huge headway.
Definitely.
So make sure the staff understands that we do appreciate that. Any public comment on this information? Future committee meetings. I actually had June 26th was a committee meeting, as well as October 2nd.
That's what we have.
And attached is the meeting minutes from December 2008, as well as April 3rd, if you'd like to see what was said. Do you agree, June 26th? Okay. So mark your calendars, June 26th and October 2nd for licensing committee. Okay, Mr. President, that's my report.
Well, thank you very much. Good job, Debbie. Let's take a 10-minute break before the next Enforcement Committee report. Okay, we're back into session. The next item on the agenda is the Enforcement Committee report. The chairperson being Mr. Alan Shedd. Alan?
Okay. Now, just to kind of give you a sense of time frame, Debbie had 7 items and I have 15. So, yeah.
We have the sleeping bag here already.
Are you done yet?
Yeah, you know, I'm impaired, so.
Oh, you're impaired. Okay. Oh, yeah.
There you go.
All right, we'll start. This is the Enforcement Committee May 14 meeting. Item 1, presentation, discussion, and consideration of ethics course provisions in the California Code of Regulations, Title 16, 1773.5. In the chair report are the requirements for the board's ethics program as established by CCR 1773.5. The board currently uses this program as a disciplinary item in certain administrative cases as well as in certain citations as an order of abatement. During the committee meeting, we received a presentation from a representative of IMQ, Institute of Medical Quality, regarding the content and objectives of the IMQ course. It includes a full 2-day program followed by a 6-month progress report and a 12-month final report. We were told that IMQ uses a pre-test and a post-test and it costs $19.95. That's $1,995. Following completion of the course, participants are provided a satisfaction survey. Our committee received public comments in support of the ethics program. Further, it was suggested that such a course would be beneficial for pharmacy students. The committee requested that moving forward, a report of the satisfaction surveys be provided to the board on an annual basis. Additional information is provided in the meeting materials, and a copy of the presentation is there also. Any discussion from the board? Discussion from the public? Item 2. Discussion and consideration of Senate Bill 1442. This recently enacted legislation prohibits a community pharmacy from requiring a pharmacist to work alone unless specified conditions are met. The committee reviewed DEA requirements related to required background checks for employees. Pharmacies need to be mindful of these federal requirements when implementing the bill's provisions. Senator Stone addressed the committee and requested that inspector staff conduct after-hour visits to observe activities that happen in pharmacies. He requested that the staff ensure that the measure is appropriately implemented throughout the state. As part of the discussion with Senator Stone, President Law suggested that Senator Stone consider amending the law to clarify that the pharmacy technicians would be required to provide assistance under the conditions of the measure. This is especially timely in that the committee also received public comment that the retail staff sent to assist the pharmacists under the provision of 1442 lack the training, knowledge, and skills necessary to provide assistance to the pharmacist. Additional information is provided in attachment 2 and includes a copy of the bill as well as relevant chapters. Any board discussion? Public discussion?
I'd like to comment on it.
Okay, great.
Because I talked to many pharmacists and I'm finding that they are not getting the help. And I've talked to pharmacists in every company, Vons, Albertsons, Rite Aid, and I'm being told that they are not getting the help. And a lot of the pharmacists are afraid to say anything because of retaliation, but when they ask for the help, they are not getting the help. So we have to have some way of enforcing this.
Oh, okay. Now, I see later in the agenda in item 14, there's a petition by, is there any information on that that's relevant here to your discussion topic?
It's a separate agenda item, but yes, there is a petition for regulation under this statute that's been filed by UFCW under the APA.
Oh, that's just my comment.
Oh,
Actually, are there any comments? That's my comment.
Okay. All right. All right. Okay. Oh, Steve.
Steve Gray is an individual pharmacist. So I guess the question asks is, I noticed that the Enforcement Committee report came out as no action. What was the feeling of the Enforcement Committee regarding how much or how strong this new statute, which requires pharmacists to have help and not to work alone, what was your recommendation to the whole board regarding enforcement?
Well, with this additional information from our board member here, and from the information that was presented, it seems like at the moment it's a hollow issue. We're not enforcing it. We're not looking into it, and this is inappropriate. And so we do have to take some action on it. What action, we haven't decided yet. But you bring up a good point. What to do about it? Is this another situation, kind of like consulting, where we want to have action on it and we don't have a way of truly enforcing it? Any comments, Steve?
Well, my comment would be that part of the reason we had this Enforcement Committee meeting in December was for the Enforcement Committee to be able to recommend to the board enforcement policies on law changes, and this is certainly a significant law change. And to hopefully make a recommendation, and the whole board could discuss how it should be enforced before there was an actual case. So then the board might be prohibited from having an open discussion about it. So I don't know if there's an actual case now under consideration. It doesn't sound like it, but I don't know. So there ought to be some discussion and maybe even some motions or direction to staff about enforcement.
Oh, we have more comments.
Good afternoon. Thank you for hearing on this issue. My name is Song. I'm a pharmacist in San Diego. Last year, I spoke before the Board of Pharmacy in support of this law, SB 1442, because pharmacies were chronically understaffed and it prevented us from putting our patients first. Many pharmacists, as you all know, around the state always have been put under unbearable amount of stress, working alone, handling 10 to 15 tasks at the same time, ranging from taking phone calls from patients and doctors, intaking prescriptions, processing vaccinations, filling prescriptions, verifying and releasing medications, and contacting insurances as needed. In addition, thanks to SB 493, we're expected to provide travel immunizations, naloxone dispensing, and birth control services. Most importantly, we're held to the highest standards of corresponding responsibility when dispensing opioids and other controlled substances. And we're all expected to do all this in addition to ringing up groceries and other store items, such as toothpaste. When SB 1442 was signed into law, I thought things would get better. I looked forward to finally having the help I needed in the pharmacy. I thought we would finally be able to focus on doing what's the most important for us, is taking care of our patients and giving them full attention they deserve. I'm very disappointed to report to you today that this has not happened yet, and there's no sign of any progress being made. Many stores are flouting the new rules, and I hear from my colleagues around the state that many other companies are doing the same. In some of our stores, managers twist the language in the law, definitions like make available and assistance, to fit their own interpretations and keep pharmacies understaffed. Without consistent enforcement, they're free to make up their version of the law. It is also troubling to report that some of my colleagues were told having assistants, meaning someone standing outside of the pharmacy while a pharmacist is giving a vaccination in a room. And now my fellow pharmacists are even fearful to report violations because pharmacists who have stood up for their patients under the new law are transferred to different stores or given different shifts. In addition, many pharmacists are scared to report violations as companies and the board could blame each of their pharmacist licenses instead if violations are reported. The board is hearing a petition from UFCW tomorrow asking for implementation and clearing the ambiguity in the law to help me and my fellow pharmacists focus on our core responsibility to keep our patients safe and protect the public. I strongly urge the board support for the petition to ensure SB 1442 is enforced for the protection of patients and to stop any retaliation. Thank you for your time.
Thank you.
Albert.
Microphone.
Not working?
There goes.
Do you know what is the rationale that they don't hire enough staff to run the business? Because I mean, the limited staff, there's limited business they gotta do. So I mean, if they have more prescription to fill than the people doing the filling, how can they make money? So what do you think is the rationale behind this?
Well, I think one of the problems I see is a lot of companies who are running pharmacies around the country and the state are operated and managed by non-pharmacists. And I unfortunately believe those folks do not have complete understanding of what it takes to run a pharmacy. And they sometimes may look at spreadsheets and determines their rationales, but I can't come to understanding.
I agree with you, Albert, and I actually spoke with someone and asked them why weren't they giving the help to the pharmacists, and they told me it's too costly.
But it takes money to make money.
Thank you for your comment. Go ahead.
Hi, my name is Nick Matwani. I work for Rite Aid, and I'm a pharmacist. I'm talking about the same issue that we are, experiencing at this time. SB 1442 was passed so that we pharmacists can get the better help and we can provide good service to the patient, also do our consultation and other things that are required by the board. But that hasn't happened because we are always left alone many times. Because it says that no pharmacist left alone. Now, as a pharmacist, my role has expanded a lot. Before we just used to dispense prescription. Now we are doing vaccination, counseling, DUR, cures, preventing misuse of any cold medication. So we are doing quite a few other things besides just being a pharmacist. If I don't have any help, I don't have any time to do all the things I'm supposed to do. When there is no help, I'm doing the work for 3 different people, a technician, a clerk, and a pharmacist, which all combined together. My opinion is the only problem with the corporation is make more money with the less staffing and try to generate as much money as possible. That's their view, but they don't consider public safety as their priority.
Okay, thank you.
Thank you.
Go ahead.
My name is Delphine Hicks, and I am a pharmacist at Rite Aid. At Rite Aid, I work as a relief pharmacist who travel daily to different stores within the San Fernando area. Last year, also, I was a part of the group of pharmacists from across California who shared story of retail chain companies compromising patient safety for understaffing pharmacies. And it's after our action that Governor Jerry Brown signed SB 1442, a bill that promised to protect the public health. Unfortunately, I'm here to talk from personal experience. Last year, for example, I was in a night shift. Night shift, I had to work alone from 11 p.m. to 6 p.m. I went through two robberies. This year, as a relief pharmacist, I go from store to stores. No longer than 2 weeks ago, I was in Panorama City where I have to work alone from 7 p.m. to 10 p.m., doing all the list of duty that was earlier listed that pharmacists have to do. I was told that the solution was that front-end store manager will provide us with help from the staff. But the reality is that the front end itself is understaffed. So the store manager, when we call for help, they don't have enough help to provide out even with a clerk. Sometimes the clerk shows up, but it's just for a few minutes and have to run to the front end. And we even end up ringing up all the customers coming from the front end. So unfortunately, this SB 1442 was not reinforced. Tomorrow, the Board of Pharmacy is hearing a petition from the union UFCW asking for uniform implementation and clearing the ambiguity in the law to help pharmacists focus on our core responsibility, which is to keep our pharmacies safe. As a pharmacist, I strongly urge the board's support for the petition to ensure SB 1442 is enforced for the protection of patients. Thank you for your time.
Okay, thank you.
I have a question for Alan. I guess it's just background from myself. From what I'm hearing, the bill that passed did not meet the need of the community. And I understood that the bill, maybe I misunderstood, that the bill itself, which is SB 1442, was about the safety and security of the employees of the pharmacy, so the pharmacist would not be alone. There'd always be another individual in the environment. But what I'm hearing from our testimony at this meeting and other meetings, it's not about having an individual there, but that was not the intent of the bill, or was the bill not clear? Yeah, thank you. I'm just trying to get the background, because what we're hearing testimony on is not in what was in the bill. The bill was about the safety and security of the individuals, but the need appears to be about workload.
Well,
That's related to the safety of the individual.
well, now wait a minute here.
Confused.
I'm under the impression that it was to not for the safety of the safety and security of the pharmacist. It was for the safety and security and increased protection of the public, to make sure that the pharmacists would not be overly burdened if they're by themselves. And I think that was the thrust that Senator Stone and who was the main carrier of this bill? Senator Weiner, that was their intent. And so the idea of just another person to hold the pharmacist's hand in case of a untoward situation, it wasn't the security.
That wasn't the purpose.
That was not.
But that was what was passed.
No, it wasn't.
Because the past did not include about being a pharmacy technician or
No,
anybody who's
it
worked
did-
in the pharmacy. What I understood past was about an individual, and what the need is somebody who actually can work in the pharmacy.
Well, that's the intent and what was actually passed were two different things. So you are correct in perhaps what was passed. The intent was not covered completely in the bill. And so that's one of the reasons we recommended some changes to it. And I imagine that's the reason that these people are here
Right.
to support. changes that are coming up.
Alan, it's a question for Ann. Is this a ground for citation? Can they issue citation based on this?
Yes, so without saying too much, I'm looking at counsel. Do this if I start talking too much. We have received and are looking into some potential violations.
Okay, that's good.
And I just wanted to respond to Maria's point, which is just that I agree that the language is less definitive than I think would have been Senator Stone or Senator Weiner's intent. But it does say that the person shall be made available to assist the pharmacist. So it's not just about personal safety of the pharmacist. There is supposed to be an assisting component. What that means and how far that goes in terms of enforcement discretion of the board is another question that will have to be decided by cases on a case-by-case basis, but absent further regulation. But it is supposed to be, and there's, if you look further in the statute, there's ways in which by the ways in which enforcement action is not supposed to be taken, it defines only those circumstances under which that assistance is not supposed to be provided. That's if someone's ill or whatever. So it does seem to set up an expectation that there will be actual personnel to assist the pharmacist. You're right that it did not place any licensure requirements on those personnel, which would have been, perhaps ideal in terms of placing those people in doing pharmacy practices.
And if I can just say, that's part of the reason that I think the committee was talking about what DEA requirements are, so that people that are being deployed to assist or should be deployed, however you want to say, so that people would understand what those background requirements are so that people aren't being set up to fail.
It's also my understanding, and it was stated here again today, that the pharmacist is being required to do a lot of non-pharmacy related things, like toothpaste sales and so on and so forth, and that this person was supposed to be able to relieve the pharmacist of those other duties so that the pharmacist could concentrate on the pharmacy duties. And that overall was to be for the protection of the public so that the pharmacist could provide safe medication to them.
Well, actually, this law went into effect the first of the year, and this is already the May, which is 5 months, almost 5 months past, and I'm totally embarrassed that we're still hearing people complaining about that. It was like a total disrespect of the law, disrespect of the Board of Pharmacy, and I will take that into serious consideration, and our interim executive director and the staff will really look into it and do something. So I want to thank you all for your comment.
Yeah, so can I just say one thing? So only because I've heard it from a couple of different people about people being scared to file a complaint with us. So I am so not an attorney, so let me give some serious disclaimers. But I do believe that there are whistleblower protections, if you will, for people that provide information to state employees for purposes of investigation. So to the extent that people maybe are not filing complaints with us, they might want to look into that.
Would you like an actual attorney to supplement that information? Or
Do you know one?
I mean, I don't think I can give specific citations of the California Whistleblower Protection Act and things, but I don't think we need to do all that. But I will just confirm that you are correct that there are several sources of law in California law. Some are specific to particular kinds of proceedings, and then there's one that's sort of general to all kinds of complaints that you might make. And it has very broad language, so it doesn't have to be to a particular proceeding. It has to be just sort of making a complaint to a government agency or government employee of some sort is protected activity. And what it protects against is retaliation by anyone, an employer or otherwise.
Okay, yeah, go ahead.
Hi, Jennifer Snyder on behalf of the California Retailers Association and the National Association of Chain Drugstores. Just want to make a really quick comment. We were part of the discussions with respect to the passage of SB 1442, especially during the time that it was heard in the Assembly Business and Professions Committee. And I just want to make it clear from our perspective, the dialogue that led up to the language that was in 1442, we believe was based on concerns that were raised when pharmacists were working alone, but needed a period of time to either take a break or a period of time where someone could help them for a short period of time. And it was important from our store's perspective that there would be a person available at all times to help the pharmacist, but they could also be doing other duties in the store when they are not needed. So that is why it was somewhere, that's why the language was drafted in Assembly BMP the way that it was. And that's why we moved to a neutral position on the bill. So I think there's a lot of different perspectives about the intent, but I just at least wanted to make it clear from the store's perspective what they feel that the requirements are. I would encourage the board fully support making sure that this new law is enforced. I would encourage you also to make sure that that our pharmacies know about this new law. Again, it has been a while, I would agree, but it does take pharmacies time to implement. And so I do think it's important for them to know the new law, and the board should take on that responsibility of enforcement and see where you can go with making sure that at least the 1442 is being implemented properly. Beyond that, I would think sometimes we can have a discussion tomorrow about the petition and other things, and I can wait till then for more comments.
Thank
you for your comments.
Yeah, thank you very much.
I want to ask the enforcement committee members if you guys would agree, maybe to give them a first warning citation with no fine, and then if we find subsequent violation, then will be a heavy fine for them to be compliant. I mean, that way they will.
I think this is the. I think we better discuss it
in the committee,
in committee, because
something that we could.
We have to implement some type of action. The comments here, Steve's comment, it seems like in a certain way, maybe the enforcement committee hasn't taken enough aggressive action on this to implement some way that we can put the public at less risk during these times.
Any other public comments?
So can I just quickly say one thing? So as you're moving through this, if you want to create a standard by which every single investigation results in a specific kind of outcome, that's would need to be in regulation. So providing policy suggestions for staff to consider is an alternative way if you don't want to go through the full rulemaking process or a statutory change.
Right. So, Paige Talley with California Council for the Advancement of Pharmacy. Excuse me, I have to agree with Jennifer Snyder based upon the hearing down in San Diego. It was that the pharmacist needed someone if a female pharmacist had a UTI, or, she'd have to wait hours before she could leave the pharmacy, and that was unacceptable. They were having to pick up trash, that sort of thing. So that's why the verbiage is the way it is. But I thought at the last committee meeting, and Anne broached it today, the issue was, can a person that's in produce or in dairy come in and help and assist for a few minutes or an hour or two or whatever, and do they need to to have a criminal background check. Can they be in the pharmacy, legally? I thought that was a big discussion, and maybe that needs to be followed up on as well. And I know that, Victor, you suggested to Senator Stone when he was here that why doesn't he just amend the bill or amend the language to just have a pharmacy tech there, and that would solve everything. Yeah.
That will be subsequent.
So, yeah, I just wanted to remind the chair of the committee that.
Me.
Yes, it is. All right, thank you.
Steve Gray again, as an individual pharmacist. I disagree completely that the intent of the bill was just to provide someone to cover bathroom breaks or something of that nature. The bill is clear on its face, assist the pharmacist. The reason it didn't have a technician, and this was discussed, was because there are a lot of things that the pharmacist or the pharmacy does that don't need a technician. All of the interactions with inputting a prescription don't have to be done by a technician. All of the receiving of the prescription and making sure you have the address don't need to be done. None of the cashiering activities have to be done by a pharmacy technician. Calling the doctor for a refill authorization does not have to be done by a pharmacy technician. So it wasn't necessary to have a pharmacy technician there necessarily after hours. That might be nice, but that's why it wasn't a pharmacy technician. But it's to assist. It's not to guard the pharmacy, cover the bathroom breaks, or anything of that nature. That is, if you listen to the public hearing that was in Fullerton on this subject and what was described, it was more of what these pharmacists testified here today. They're trying to do what they're supposed to do. They're trying, if after hours, nights and weekends, when there is very difficult getting a hold of prescribers. We all know that. When people are coming in from urgent care clinics because they couldn't go to the doctor's office, it's not a weekday, from emergency rooms with controlled substance prescriptions. They're trying to do what you wanted them to do, which is to check the cure system to make sure someone isn't doctor or pharmacy shopping after hours. Trying to get a hold of someone at a PBM in order to get coverage exceptions or clarify all of this. These are things that don't have to be done by a pharmacy technician. They can be done by an assistant. The common term now for pharmacy ancillary help is assistant. Used to be clerks, used to be cashiers, and so forth. So I don't think there's any ambiguity in the statute whatsoever. It says to assist them at all times. And so that's what needs to be, the policy of the board. Yes, we want to hear the petition, but do we need to wait for regulations to clarify whether it's a cashier, a clerk, assistant, a typist, someone to clarify the stock or something? I don't think so. I think that is not what was intended. And if you read the attachment to your meeting materials today, it was clear to me that Senator Stone didn't think that either, and he urged enforcement of this in the attachment and what was reported. And so I think that a policy statement or a direction to staff, and maybe they don't need it because it may be that they're already going down that path. God bless them if they are. But the point is, it's May, folks, for something that was the law January 1. Thank you.
Yes, your point is well taken.
Well, and it is unusual for the author of a bill to come to the pharmacy board to request enforcement.
Can I interject here? I feel like we're going to have a lot of back and forth about what the statute means between various advocates for both sides, which I don't think is a good use of this board's time. So it's obviously up to the chair of the committee, but I feel like the statute is what it is, and your staff are going to enforce it. Your counsel are going to advise on that enforcement. I don't think this is the venue for a public discussion of what the statute means or not.
Right.
Well, and
Well
to
said.
add to that, if there are particular enforcement cases, they wouldn't be appropriate to be discussed right now. Those should be filed as complaints, and then they can work themselves through the process.
Okay. Got it.
Go ahead.
Jennifer Snyder, I was only just going to add one more thing with all due respect to Steve Gray. He is not the author of the bill, nor is he the sponsor, nor was he part of any of the discussions with the Assembly BMP committee. So, and Senator Stone was a co-author of the bill, but was not involved in any of the discussions and any of the dialogue that happened with respect to the bill. So I think it's important to talk to the author's office, the sponsors, when we're talking about intent.
Thank you. I appreciate that. All right. Shall we move on? Oh, moving on. All right. Item number 3, presentation on the board's routine pharmacy inspections. The committee received a presentation from Board Inspector Stephen Kyle on the inspection process. Following the presentation, we were advised that the board staff intends to record a future presentation similar to the one provided, and will ultimately put this on the board's website. A copy of the presentation is included in the meeting materials. Item 4, update on the discussion of the board's citation and fine program. Goal 2.10 of the board strategic, pardon?
Public comment.
Pardon?
Public comment on that
public
first.
comment? Better not be any. All right. Update and discussion of the board citation and fine program. Goal 2.10 of the board strategic plan calls for evaluation of the citation and fine program. During our meeting, the committee focused its review on 2 specific areas of this goal: post-evaluation of the order of abatement provisions since May, and review of the policy considerations and guidance staff that have been provided by both the president and vice president as it relates to completed citations with issues with fines of $2,000 or greater. During the meeting, we reviewed data that demonstrates that orders of abatement are used with a far greater frequency than in previous years, which is consistent with the direction of the board. Whereas in the 2016-17 financial year, about 1% of the citations were issued with an abatement order, and this year 20% contained such an order. During the meeting, we noted that the number of abatements accepted is relatively low, and were advised that the individuals are typically provided with a period of time to comply with the order. The committee will be provided another follow-up report to evaluate the compliance rate. In addition, the committee reviewed the summary suggestions that the president and the vice president have provided to staff regarding these citations. The suggestions are detailed in the chair report. As each investigation is unique, each case must be individually reviewed to determine the appropriate outcome. Additional information is provided in the meeting materials in attachment 4 that includes the relevant law and a copy of the fine and citation flow chart. Now, I did look at that chart, and I was wondering, fine chart, and I was wondering if there was, sometimes there's an office conference. Where should the office conference go on that chart, or should it be in there? Can't believe you don't have it right at your fingertips. Here, look at mine.
So where it says appeal process?
Where are you here? Oh, that's
Where it says appeal process at the bottom, and then it can go to office conference or it can go to AG's office. That's the appeal process, and it looks like it truncated because someone can appeal to an office conference, and if they disagree with the outcome of that, they can still appeal to the AG's office as well. I apologize that it cut off.
Okay, good. Thank you. Okay. Board comment? Public comment?
Well, as you guys could see, from 2016, 17, and now to 2018 and 19, the number of citation has decreased significantly from 1,600 to only 800. And this, from a $2 million fine, it has been reduced to only 800,000. So you could tell that the board is moving to the educational mode of educating pharmacists rather than levy heavy fines and citations to you all. But that's the only area is that's how you know that we will have a deficit of like a $1.2 million because of the fines that we're not getting. That's the other side of it.
Who was president during that year? Discussion.
The one who is not present right now.
Number 5, discussion and consideration on efforts to reduce investigation times and case resolutions. Goal 2.1 of the board's strategic plan seeks to implement process improvements to shorten cycle times, with a special focus on prioritized critical cases to minimize patient harm and to enhance consumer protection. For several meetings, we've been discussing investigation closure times and receiving updates on current data. Included in the chair report for review are pending data as well as case closure data. Review of the age of field cases closed reflects improvement in overall investigation times for cases that have been closed. As a committee, we'll continue to monitor these investigations time and provide full updates to the board. Yes, again, like Victor says, the staff has really paid attention to the board and shortened those times. Okay, item 6, discussion on Attorney General Annual Report on accusations prosecuted for the Department of Consumer Affairs. Goal 2.5, the board's strategic plan, is to evaluate the disciplinary process and initiate improvements for enhanced efficiency and effectiveness. As required by law, the Office of the Attorney General is required to publish data annually on disciplinary matters. During the committee meeting, Senior Deputy Attorney General Joshua Room provided additional information. He noted that board matters may not move as quickly as some other programs within the DCA because of the case complexity and the number of respondents in each case. Additional information and relevant portion of the AG's report are included in the meeting materials. Board comments? Public comments? Okay. Item 7, discussion and consideration of AB 2138, licensing boards, denial of application, revocation or suspension of licensure, criminal conviction. This committee previously discussed this measure, which places restrictions on the acts and convictions the board can consider when making a decision on an application. During our meeting, we discussed 2 aspects of this measure. We discussed statutory changes that, if enacted, could restore some of the board's licensing decision authority for specific types of conduct. Number 2, review of proposed regulations that are required to be promulgated as part of the requirements established in AB 2138. Regarding item 1, the committee reviewed language that would provide statutory changes to allow the following. 1, consideration of convictions of felony financial crimes. 2, acts that would be grounds for denial of a federal registration to distribute controlled substances. 3, acts that involve fraud in violation of state or federal law related to health care. An example would be Medi-Cal fraud. 4, convictions related to identity theft. 5, convictions related to the sale of counterfeit products. The committee agreed with the proposed statutory change and have provided the following recommendation for board consideration. This is provided in Attachment 6. We have Attachment 6 handed out here. There's copies of Attachment 6 in the back of the room if you'd like to look at them. It's the last 3 pages that we're concerned with. Those last three pages, starting with Pharmacy Board AB 2138 draft regulations as recommended by the Enforcement Committee on March 14th, 2019.
Well,
Yes, please.
the first item that I think you were just reviewing was the statutory change, which is actually a few pages before that.
Oh my God. Where?
What page?
And
What page here? The page before those 3 pages? 3 pages before those. No, 3 pages before those 3. Oh, right here. Okay.
And if I could clarify, I think on the online version, because when it was converted for accessibility purposes, I think the underlining got lost. So the copies that are in the back do have the underlining.
Have the correct underlining?
Edit. So if you have underlining, you're looking at a copy.
And I noticed that this still doesn't have the possible relation back amendment that we were talking about. Are we going to still pursue that or no?
Yeah, and actually there's pending legislation right now that I think gives us good language that we could mirror to
Okay.
add in. But I believe that's part of the recommendation.
Okay, thanks.
So, to move forward at this point. So it's the last 6 pages that we're concerned with. The first 3 refer to the first item. Yeah, okay. And the last 3 refer to the second item. Okay, I've got it now. Okay. Well, the committee motion would be to recommend the board seek an author to make the statutory amendments as included in attachment 6 to include language specific to criminal history. Now, could we have a motion to that effect?
That's the committee recommendation.
Right.
Any comments from board members? Public comments? If not, let's call for the vote. For all those in favor, please raise your hand. Unanimous? Okay,
Great.
motion carry.
Great. Okay. Oh, let's see here. Do we need another motion to recommend that the board approve draft regulations to include section 1 with optional language, subdivision C to include option A without the variation, make non-substantive changes consistent with the policy direction?
Yes. The second one. Second motion.
Okay. Are you causing trouble, Josh? Oh, I know it's not in your nature. Thank you.
Well, I wanted to make sure, I'm sorry, I wanted to go back to the conversation that you and Ann were having and make sure we captured the piece of it. Okay.
Right. Yeah. So
Okay, then we're good. Sorry about that.
Okay, so that's the committee recommendation. Any,
Where is that in this packet?
The motion from the committee was for the action that you just took. It was recommend the board seek an author to make statutory amendments as included in the meeting materials and include language specific to criminal history.
oh, the second one.
So here, so the challenge here is that you're looking at what the committee did and the motion that the was made, but the materials that are in the in item 6 reflect what was in option A at the.
Is that it no longer says option A because the committee directed staff to put that into the full proposal. So the language that you have is what the committee has recommended that we consider with respect to that, because that's what their motion was to staff. So we then included the language that was in option A into the proposal moving forward.
Okay, is everyone clear? All right, any public comments? Seeing none, all right, let's call for the vote. All those in favor, please raise your hand. Unanimous? Okay, motion carry.
Now, do we need to have a motion to initiate rulemaking or not?
So I would recommend that you do that because you've just approved the language. So now the motion to initiate the rulemaking, delegate if you feel appropriate, the authority to make changes consistent with board policy, et cetera, would be helpful.
All right, then we with the motion.
So we so move. Is that the
Move by,
So committee did not recommend that piece. They recommended the language.
And
Now
so-
it's to move it to reg.
all right, moved by Greg. I'll second that, And any other comment?
If I would recommend that the board also delegate the authority to make changes consistent with the policy to its executive officer, which would include the interim executive officer, consistent with the board's policy.
Yes, agreed. I amended that too.
and recommendations of the control agencies. All right.
Okay.
Well, that's the final action we're talking about the beginning.
Oh, I got ahead of myself.
So yeah, so just in case there's any
God.
inconsistencies, this gives Anne the ability to make the policy consistent throughout the regulatory
It's a good thing you're here.
document.
All right. Any other public comments? If not, let's call for the vote. All those in favor, please raise your hand. Unanimous? Okay, motion carried.
And now? Do we need another motion? No, good. Thank God. All right. Item 8, presentation and discussion of disciplinary guidelines. These are in attachment 7, paged. Members of your organization have asked for a copy of the disciplinary guidelines, and they're in attachment 7. Just, okay. During the meeting, we heard a brief overview of the board's disciplinary guidelines. The guidelines are used by the board and others in reaching decisions in administrative matters. The guidelines detail the factors to be considered in determining penalties as well as the mitigating factors. Further, the guidelines provide categories of violations and recommended penalties. The guidelines provide model language and terms and conditions of probation. It is the intention of this committee to complete further review of the guidelines in the next few committee meetings to determine what changes should be recommended to the full board for consideration. We do not take action, but will keep the board apprised of our efforts as we continue the review of the guidelines in our future meetings. Comment? Item 9. Presentation by the California Pharmacists Association on a proposal to modify the board's current enforcement process. During the meeting, the committee received a presentation from Danny Martinez and Veronica Bandy on behalf of CPHA. The presentation focused on the establishment of a pharmacy advisory committee to review investigations prior to the initiation of the formal disciplinary process. Mr. Martinez indicated the board should permit licensees to go before a consortium of their peers in order to help the board prioritize issues. The committee expressed concerns, including conflict with the board's mandate of protection of consumers, and a recommendation from the consortium of only pharmacists is in opposition to the concept as well as the construct of the membership of the advisory committee. Further, council highlighted several legal obligations that would be putting members of the board in greater jeopardy for antitrust violations. Specifically, we were reminded about the issues of antitrust and possibilities of treading too close to the line of having licensees exclusively policing other licensees under the North Carolina Dental Board case. We also considered alternative models and provided during public comment. Ultimately, we did not take action other than to direct board staff to explore alternative solutions for the committee to consider. Has there been forward motion on that yet? No, because bringing it back to the next enforcement committee meeting. Okay. More comments? Danny?
At the risk of another tongue lashing,
no,
I just want to say I appreciate the board's willingness to keep this conversation going. I think this is still an important issue. Many of our members and pharmacists around the state really do want to get to a point where there's some sort of a peer review process for disciplinary issues. Whether our specific proposal was obviously not well received, and that's fine. The point of that proposal was to continue the discussion. And we look forward to the next enforcement committee to work with the board on alternative proposals. So
we look forward to seeing you, Danny.
Absolutely.
Thank you.
Okay, item 10. Review of the final final report submitted by UCSD, the experimental program regarding access to medications from an automatic drug delivery system. Attachment 10 includes the updated study information. The study will end in June 2019, and the board should expect to receive a final report in the fall. During the study, 1,496 new prescriptions have been delivered via the delivery system and 1,650 refill prescriptions, and there have been no complaints filed during the period of the use of this device. Any comments, board comments? Public comments? Good. Item 11, discussion and consideration of proposed changes to the self-assessment forms. The self-assessment forms are a compilation of relevant laws that are intended to allow the entity to self-evaluate for compliance to these laws. As a committee, we review the proposed changes to the forms incorporated in the reference in section 1715 and CCR 1784. Because the various forms are incorporated by reference in the respective regulation sections, a regulatory change is necessary whenever the forms require an update. The prior version of the self-assessment forms are currently undergoing promulgation. So 5, our motion is to the staff. Our committee reviewed the staff assessments, which are included in attachment 10, and are recommending the approval of these drafts. So that was the motion. The staff the committee recommended. Public comment? Board comment?
Okay, that's the committee recommendation. Any members, board members comment? Public comments? If not, let's call for the vote. All those in favor, please raise your hand. Unanimous? Okay, motion carried.
You can say whatever you want.
So while the rulemaking process is going forward, at the staff level, we will be posting these updated drafts because we think that the self-assessment process is more meaningful with the more updated. But by law, people can do the one that's incorporated by reference or the more meaningful.
Great. No, that's very important. Item 12, discussion and consideration of Title 16 CCR 1715.6 related to the reporting of drug losses. As part of the board's discussion on the development of its inventory reconciliation requirements, the board's requirement to report drug losses was mentioned. As included in the chair report, an owner is required to report any loss of a controlled substance, including the amount and strength, and this must be made to the board within 30 days. Previous discussions noted the difference between our law and DEA reporting requirements. Included in the chair report is data for both loss reports for several fiscal years and the first 6 months of financial year 18-19. The committee did not take action on this item, but requested that staff survey other states regarding their drug loss reporting requirements, as well as search the types of drugs included in 1 to 100 dosage unit threshold noted within the data. Was there... Okay, we'll be reporting back in the next enforcement committee. Good. Board comment? Public comment?
I know it's been a long day. I'll be very brief. I just want to add one more element to probably your search, and that is for compounded drugs that are controlled. To measure them means you would have to dump them out. Say you get a kilogram, or which is what, around 2 pounds, or a small fentanyl bottle when you're making fentanyl patches and stuff. You'd have to pour it out, and then you lose some of your powder. So they can't really measure them. How are they expected to report drug losses?
Yeah, go ahead.
I think that might be more of a function of the inventory reconciliation regulation that is not on the agenda, but happy to have that discussion with you offline.
Not really. Right? It's drug loss.
I think what you're
talking about. Are you talking about dumping it out for purposes of doing the inventory reconciliation?
Well, and then there would be a drug loss.
Yeah.
So they're connected.
You know, I see what you're saying there, Paige. I think that's something so specific that we'll have to talk about that.
No, I understand. I just wanted to get the wheels going.
Yeah, I think that's such a special case that somehow that can be accommodated with common sense rather than.
Okay, all right. But this will be discussed at the next enforcement committee meeting, right? I mean, the whole drug loss issue.
We'll talk about it some more, but I don't want to get bogged down in the individual. I mean, there's 100 cases of individual items as far as the compounding situations, and so we'll come to some understanding of some reasonable way to do it.
Right,
We
okay.
don't want to lose product, no.
Right. All right, thank you.
More public comment? Okay, great. Item 13, discussion and consideration of draft FAQs resulting from the board's Ask an Inspector program. The Communication and Public Education Committee is evaluating the board's Ask an Inspector program. One of the outcomes of the work of that committee was directing staff to develop FAQ based on the questions received. During the January board meeting, it was suggested that the draft FAQs be vetted through the Enforcement Committee. The committee deferred discussion on this item to our next meeting. Item 14, discussion and consideration of the board's enforcement statistics. Attachment 11 includes enforcement statistics for the first 3 quarters of the fiscal year. As indicated, the board has received 2,229 complaints and closed 2,160 investigations. And in addition, the board has issued 879 citations and referred 193 investigations to the AG's office and secured 8 immediate protection orders and 3 cease and desist orders. Now, this struck me as kind of interesting. Can you make any comments on those? Yeah, the immediate protection orders. Tell me about what that
So
would
typically that's either a Penal Code 23 restriction, where we have sought through the criminal process to suspend someone's license while the criminal process is moving forward and we're doing our administrative case.
Okay.
Or it could have been an interim suspension order where we went in through the AG's office through a process to seek immediate suspension of it while the formal discipline goes through. And the threshold to secure that is very high.
And when you say the threshold to
secure an interim suspension order, it's very difficult to do.
Oh, okay. All right. Item 15, future committee meeting, July 2. And as Chairman Veal says, mark your calendar.
Thank you very much. Well, it didn't take an hour, so. All right, let's move on to the next agenda item, which is the compounding committees. Chairperson being Dr. Maria Serpa. Maria?
Thank you. I think the report will be very concise.
Perfect.
The compounding committee has met on 3 different dates, providing educational opportunity for reviewing USP 795, 797, and 800. We have one more educational meeting coming up in June that will be going over USP 825. So
what the committee meets and you just review those.
So I'm going to go through one at a time. That was kind of just an overview.
Okay, sorry.
That's okay. In our first meeting, we had a presentation by staff that went over USP Chapter 795, which is pretty much in final draft phase at USP. All of these chapters are set for implementation as of December 1st, 2019. So if you look at the report here, A is about the presentation of 795, which is pharmaceutical compounding non-sterile preparations. Unfortunately, the presentation is still not on the website, but there is a very detailed PowerPoint presentation for each of the meetings that was found beneficial by those in attendance. The first presentation reviewed 795 in the various subcategories, going through each of the subcategories of USP. And again, this was for informational, educational process for the committee. I'm not going to review the entire presentation, that's just an overview. A copy of the minutes are in attachment 1. At our second meeting, board staff, led by Chief Inspector Acosta, presented USP 797, which is pharmaceutical compounding and sterile preparations. 797 is undergoing final review and update by USP. A current draft is available, and that's what was reviewed and presented at the meeting in March. It is expected that USP will present their final draft in sometime in the month of June. I don't have the exact date. June 1st, right around the corner. And then that will be the final draft. As of now, what we have available to us and what was presented to the committee was a current draft. And just to remind you, current USP 797 was written in 2008, and that is what is currently the regulation. The new regulation, as with all the other USP chapters, will be implemented December 1st, 2019. During the presentation, the various sections of USP, which there are about 20 different subcategories, was reviewed for the educational purposes of the committee. And those are, the minutes for that is listed in attachment 2. At our third meeting, we reviewed USP Chapter 800, Hazardous Drugs Handling in Healthcare Settings. This, although still says draft, is final and has been final for some time. Its implementation by USP has been delayed such that all the chapters would be implemented at the same time. So again, that's in December 1st, 2000. I keep repeating that because that's an important date to us in our pharmacy world. At the April meeting, the presentation went through the various components of USP 800, and that is a very complex chapter. It includes, again, about 20 subcomponents. Some new areas are that USP has pulled out anything to do with hazardous substances, which include chemotherapy and other hazardous substances, into its own separate chapter. So that includes both sterile and non-sterile components. There is a very detailed discussion about NIOSH categories and tables and the recommendations that sites are going through, which are not really in the purview of Board of Pharmacy, but are part of USP 800 that we learned about. I think just for informational purposes, part of USP 800 is that it does review all the components of the medication safety chain for hazardous substances. That includes procurement, storage, in addition to compounding. It also includes medical surveillance of personnel and of the environment. So there are a lot of issues in USP 800 that go above and beyond the actual compounding and storage of medications. Feel free to jump in if anybody wants to say anything else.
You said that all three of them are going to be on, the videotape is going to be on the web. But they just
Not the
have to-
videotape, the PowerPoint presentation. I wanted to ask you if that's going to be posted. I know it was handed out at the meetings.
So I don't know if it's on, but we've been providing the presentation, but I think that one of the concerns was that people would take the PowerPoint and supplant that with the actual USP, because the presentations themselves are just a summary of and highlights from the document. And the concern is that if they go off of our PowerPoint as gaining or understanding full compliance with it, they're not going to get it. So I think the recommendation is that they're available online. USP has them available. Their open mic sessions are available as well. So we can put the PowerPoints online, but I think that if the understanding really needs to be that that is summary only. It is not verbatim and does not, I don't know, do we say it doesn't have a force of law? I don't know like what we do, but it's not, the intent was to frame the presentation to educate,
committee members, not to supplant what the actual provisions of the law provide or the USP chapters.
I think that's one of the challenges that we found during these meetings, is that the purpose was to educate the committee so that we are prepared to adjust regulations as needed with the changing USP standards, and that would be starting at our July meeting. However, we found that the audience found the materials educational also. So I'm wondering if there's some way to actually put the materials in with some sort of disclaimer, or what we could do to help provide some educational material. I see your point, because we do want them to go to the source document, but an overview is helpful. So how do we achieve both?
We can work on some kind of disclaimer, and we'll also have to work to make them ADA accessible, all of which can be overcome, I believe, and if not, we'll make it available in an alternative format.
Okay. Because again, especially for the USP 800, the review was of items in USP that pertain to Board of Pharmacy scope and practice, whereas USP has a lot of other information and that does not pertain to the Board of Pharmacy. So USP 800 is in attachment 3. Our next meeting, we will be reviewing USP 825, which is radiopharmaceuticals. And that, again, is all about radiopharmaceuticals, both sterile and non-sterile, and that unique environment. And so we'll be doing an educational session on that. Following the plan is to take that information and to move forward looking at current regulations and to make some suggestions for additions or changes to our current regulations to keep us in, what's the word that you used? You don't say sync, but in conformance with USP standards. That's the end of my report. Short.
That's really short. Thank you very much, Maria. Okay, at this point, I think it's been a long day. Can we postpone the Organization Development Committee report until tomorrow? Is it okay, Council? We have time to squeeze that in between. We don't have a long agenda tomorrow. Actually, we could squeeze that in tomorrow. It's been a long day. I think this is good enough for today. Thank you very much for attending today. The meeting is now adjourned.